ponder here. So we all have situations where patients come back to us after 3 months, 6 months, 1 year down the line, getting MRI scan done somewhere. Okay, so I'm still having the problem, still having MRI showing ghastly things. Nothing has healed. What have you done, doctor? So this is a very common thing a lot of us face on a regular basis. We still brag about ourselves that we are getting good results, but in reality, what are our results like? So even the best of the results range from anything between 80 to 85%. For us, we are happy because we have moved from meniscectomy to now meniscal repair, and we are doing lots of things nowadays, putting all sorts of stitches all inside out, and we are happy that we are achieving these kind of results. But are the patients happy with that? Probably not, because if we say to the patients, in all honesty, that we are achieving 4 out of 5 healing and one may not, then a lot of them may not even agree for the surgery, to be honest. So, what do we do about this? Is there anything we can do? So, in terms of when we start thinking about this, if you really look at your previous how many years, how many ever years you have done these things for, your meniscal repairs, whom you have done as a standalone, they are a lot more likely to come back and pester you rather than where you have done the ACL and meniscus. That simple thing, which makes a big difference in understanding why our people whom we have done ACL plus meniscus heal better and not the meniscus standalone. This is where we all started from. At least people started thinking as to why is this. So then, is there anything which happens when we do the ACL reconstruction to the meniscus? Yes, there is, of course. And one more thing which we all came across is regarding the effect of smoking on the meniscus healing. This is another thing which has been shown in animal studies, that the menisci which have been repaired, they don't heal well, if especially if nicotine comes into picture. So these points do towards something, that there is something which we can add on to healing. And to be honest, we all know tendon to tendon healing is a lot more difficult compared to bone healing. We all know that. And now this is next level, where in addition to healing this kind of soft tissue, in the background of all the joint fluid and everything. So meniscus to meniscus healing is a next level of thing. I would consider this as one of the most challenging in the orthopedic field. So now, is there anything we can do about it? So there are a lot of new things which are being talked about and being used as well, although we lack consensus about how much they improve and how much they really make a big difference. But there are quite encouraging studies in this regard. We are thinking about stem cells. People have used bone marrow, adipose, synovium, blood, all of these things. So these have different chondrogenic and osteogenic capability. Do they have a meniscogenic capability? We don't know yet, because meniscus is not just a structure where we have got some linear things. There are radial fibers, there are circumferential fibers. It's an architectural marvel which we are trying to replicate. So these are the growth factors have been said to improve these things. So these are the new things which are coming into picture. So initially, we all thought that, okay, we will start doing something different or more than our just a repair, and started doing meniscal rasping, trephining, or even rasping the parameniscal synovia around that area, and microfracture to replicate something what we do for the tip, to replicate what we do in the ACL. So then came the second generation techniques like fibrin clot, PRP, bone marrow aspirate, and adipose tissue, and even MSCs, which is mesenchymal stem cells. So now meniscal rasping is one of the techniques which was used even before we did we started doing the repair. So just to small tears sort of did improve by some scar tissue. So that's why this is one of the things which was commonly used. Sorry, my video is not working. Excuse me for that. But yeah, a lot of you have done that, and it's a very simple technique, meniscal rasping, or even trephination of the meniscus, where it is just a puncturing of it with small needle, where that will initiate some amount of healing response. So these are the kind of things which have been tried. And microfracture is one of the common things which nowadays a lot of us do. One good thing about that is, yes, I mean, you don't need to get a separate thing done. You don't need a PRP or a stem cell arranged for. It is straightforward right there, and just go and do the marrow venting kind of technique, which can actually improve the healing process. This is one simple technique I think we all should be at least including in all of our menisci if we don't do anything else, or if we have not prepared or kept anything else ready. So fibrin clot is one of the things which is commonly tried by quite a few people nowadays, but there are limitations to that because we can't use it in a radial tear, and it involves a bit more of technical things because we have to have the stitches on both the sides, and then without tying that, leave it loose, and then introduce the clot inside. But the biggest challenge here will be how to introduce the clot into that area, because the clot is a very fragile structure, and it will just get lost in the your portal if you are not careful enough. So for that, there are a couple of things which we can do. One is you can use the passport cannula or the normal cannula, and that can actually help you in railroading that by using a PDS. So the PRP injection, there is there are studies which are very giving conflicting opinion regarding that. The latest systematic analysis says that PRP is not something which has been changing it's not a game changer. That's what they're saying. So that is one thing which, and again, PRP comes from different ways of preparation. So is it good enough or not? We are not still very clear about that. BMAC is a lot more promising in that order. If you look at really, it has got a lot of chondrogenic property, although it may not be meniscogenic as of now. But yeah, that is one thing which has proven that it has done. It can give a better result. But again, it involves harvest site. We have to harvest it. Adipose tissue, I have not personally used it, but this is one of the things which has been promoted as a good thing to try because it's very easy to harvest that. So mesenchymal stem cells, yes, there are more and more new studies which are coming into picture now, but this is still in the research phase, and it is two-stage procedure. So that is something which is really wait and watch kind of thing. So hopefully we all can reach from where we can clinically improve the patients and make the MRIs look better and beautiful so that nobody can question us. So this was touch based upon by my previous speakers regarding anatomical reduction, biological augmentation, and circumferential compression, guys.